So the next speaker of this morning's session is going to be delivered. It's Dr. Kourosh Khaleli, who is Associate Professor at the Department of Medical Imaging at the University of Toronto. And he's going to talk about the utility and nuisances of total kidney volume measurement. Kourosh.
Thank you very much, Ulrich, for inviting me again to this wonderful conference. It's a real pleasure for me to be here this morning. We're going to start with more simple concepts than some of the earlier speakers have been speaking about. So first we're going to talk about normal appearances of kidneys on imaging, and then the typical and atypical manifestations of polycystic kidney disease. Then we'll briefly talk about the imaging mimickers of polycystic kidney disease, the utility of TKV and how to do some of those measurements that you've heard about, and briefly touch on other techniques beyond just measuring the kidney volumes. So first we start with CT scans, and of course, as you probably know, CT scans use ionizing radiation, X-rays, to acquire images. The image to your left, I'll get the laser going. So this image, this is an unenhanced scan. And so you can see that the CT scan is not very good in demonstrating the structures within the organs. It doesn't have a lot of soft tissue contrast, but it's very good in showing the soft tissues from the bones, from the fatty tissues and air, for example. So to get that soft tissue contrast, we have to take about 100 cc's of iodinated contrast dense material and inject it very rapidly using a pump and into the patient, and then you can see the blood becoming quite dense, and as this blood flows through the kidney, this is a little bit earlier, first it goes into the renal cortex and then slowly gets excreted into the medulla. And so we talk about the different phases of enhancement, the arterial phase, and this is the nephrographic phase. MR does have much better ability to depict the contrast within the soft tissues. And one thing we can do with MR is we can kind of weigh it towards showing different things. So one is a term T1 weighted, you might have heard. And on T1 weighted images, what we're doing is we're trying to show the protons. And so you're going to see wherever there's a lot of protons, so fat, for example, is full of protons, structures within the body, you're going to see a lot of signal. Whereas the T2 weighted imaging, which you've heard about and you've seen a lot of images of this morning, T2 weighted images are weighted towards showing just protons from water. And so entities that have water like cerebrospinal fluid or cysts, water within the cyst or within the bowel, they'll stand out quite bright. And other structures that don't have a lot of water, we can render them dark. So this is the difference between T1 weighted and T2 weighted images. The nice thing about T1 weighted images is that we can give contrast just like that iodine you saw with CT. And when we give contrast, you can start seeing that the blood flow goes into the kidneys, into the spleen and liver, and slowly starts filling out the renal medulla and get excreted as well, just like you saw with the CT scan. So we use contrast for MR to actually see blood flow, but in general, for imaging of polycystic kidney disease, as you heard from Dr. Perron, we don't need contrast. So in terms of ultrasound versus CT versus MR, ultrasound is a wonderful tool for these reasons because first of all, it's tolerated very well, it's very easy to do, it's available everywhere, it's very cheap, and there are no contraindications. And it does have a pretty good tissue contrast, especially if you're trying to show cystic structures versus solid structures. But it's not great in terms of reproducibility of measurements. With CT and MR, you get a standard set of images that are not dependent on who acquired them. So these are standard images. So for reproducibility and measurements, CT and MR tend to do better. MR has wonderful tissue contrast. CT doesn't do that so well without injecting the intravenous contrast. And in terms of side effects and tolerability, they're not as tolerable as ultrasound, but patients tend to do, by and large, pretty well. So now we're going to review the spectrum of polycystic kidney disease on imaging. And so these are coronal images through the kidneys, and we can see that these patients all have the severe form of PKD1. This is the protein truncating type. So the protein is not functioning or functioning very little. And so you can see in a young patient, 20-year-old female, the kidneys are borderline in size, so they're on the upper limit of normal, lots of little cysts and a few large cysts. But these patients, as they get a little bit older, we can start seeing that the kidneys grow in size beyond what's considered normal, and the cysts also grow in size, and there's very little parenchyma that's left. And so usually by age 30 and onwards, there's very little functioning parenchyma or very little visible parenchyma on appearance, and so the kidneys are very large and replaced mostly with cysts. The less severe form of PKD1 mutation, the hypomorphic types, we can see in younger patients, there's basically less severe disease. So very few little tiny cysts. If you squint, you might be able to see them from the back rows. Very few little tiny cysts when the patients are younger. Generally, the kidneys do grow. They get larger cysts, but at the age that you're looking at, it doesn't look as severe as the patients with the protein truncating PKD mutations. And also, you can still see parenchyma that doesn't look affected by cystic disease in between these cysts. And so usually these patients maintain their renal function a lot longer than the protein truncating PKD1. Also with PKD2 mutations, as you've heard this morning, there is less severity of disease, and on imaging this is manifest by fewer cysts and smaller cysts when the patients are younger, and some maintenance of parenchyma or some areas of parenchyma in between the cysts when the patients kind of get older as well. And there's variable involvement of the liver in all of these diseases, and it's hard to differentiate the hypofunctioning, hypomorphic PKD1 mutations from the PKD2 mutations just by looking at the imaging. So as you've heard, there are atypical patterns of PKD, and so these atypical patterns, we go through the different patterns. So one can be unilateral, and that's defined by one kidney being diffusely involved, like the left kidney in this patient, and the other kidney not being involved or just having one or two cysts, or having one cyst. So this is the unilateral type. The asymmetrical type, we can see, again, one kidney that's diffusely involved, in this case quite severely, and the other kidney can have severe disease just in a portion of it, or just have a few cysts, usually 2 to 10 cysts within the kidney itself. So this is asymmetrical involvement. So this kidney is going to have a lot of functioning parenchyma, and generally these patients tend to have a lot better renal function. Same with the segmental pattern, where we can see areas of kidneys on either side having multiple cysts and being severely involved or significantly involved, whereas other areas in the kidney are free of disease or just have very few cysts. And then there is the lopsided pattern where these kidneys have very large renal volumes, but the large degree of volume of the kidney is mostly due to a few cysts, typically less than 5, that have about 50% of the kidney volume or more. and that's the definition of lopsided. And so again, you can see that while the TKV in this patient is quite large, in the left kidney especially, you can see that there are large areas of the right kidney that don't have much disease, and the parenchyma is maintained, and typically function is a lot better in these patients as well. So now we're going to move on to diseases that mimic PKD, and this is important to take note of these because you don't want to misdiagnose patients. You don't want your radiologist to misdiagnose patients, and of course I encourage those of you who see patients to look at the imaging yourselves. Very quickly you can gain some degree of expertise, and if you're like York, you become a wonderful radiologist looking at these kidneys and predicting the type of genetic abnormality the patients have. So mimickers of PKD are patients that may have genetic defect, a known genetic defect, I should say, and those who we don't know of any genetic defect in them. So we'll go through some of these. So the first thing to start off with is autosomal recessive polycystic kidney disease. And in autosomal recessive PKD, a lot of patients are typically quite young. So this is a 7-day-old infant. And the images on ultrasound on this patient, because a low-resolution ultrasound probe was used, we can see that there are cystic changes in the kidney, but we're not getting a very good degree of detail. But in this patient, if we do a high-resolution ultrasound, so this is in vivo imaging in a very loud and crying 7-day-old baby, we can see that the renal parenchyma, the cortex, has actually very few cysts, whereas the disease seems to be within the medulla. And in fact, the cysts are not cystic, but these are tubes, they're dilated tubules. So this is different in morphology and appearance, and one can predict this appearance. Now, generally, these patients are very young, and the abnormality has been picked up by prenatal screening, so you can see the pathology of it, and the ultrasound you can see mirrors the histological slide very well. But a proportion of these patients don't have significant renal disease when they're born, and they make it to adulthood without renal failure. And in these patients, we can see that there is, again, a lot of cystic disease, small little cysts with areas of calcification in the medulla, but with maintenance of the renal cortex. So because that cortex is maintained with very little cystic change, that is very atypical for the other types of polycystic kidney disease, including the autosomal dominant PKD. So this is the MR on a different patient, and we can see with the autosomal recessive polycystic kidney disease, and we can see that there's very few cysts that are out in the outer aspect in the cortical area, and the cysts are much more concentrated in the medullary area. And these patients, when they make it to adulthood without renal failure, they tend to have a lot worse liver disease. They tend to have congenital hepatic fibrosis and other diseases like Caroli's. In this patient, when they're combined, it's called Caroli syndrome. Other genetic disease that are mimickers of PKD can be things like von Hippel-Lindau. And generally, von Hippel-Lindau will have all sorts of variant manifestations. Sometimes we can see one big clue to VHL as a diagnosis is presence of solid masses, multiple solid masses in the kidneys, and these are renal cell cancers, and so multiple renal cancers is a clue. But sometimes they can have cysts as well. So the arrow heads show the renal cancers, the arrows show the cysts in this patient. And in another patient, you can see there is quite a bit of cystic disease within the pancreas, so that's another clue with VHL, but we can see that there are also a few cysts in either kidney as well. Tuberous sclerosis complex generally affects the kidney with lots of small little angiomyolipomas. Sometimes they're not that many, they're variant manifestations. And if you heard this morning from Dr. Wernick, there is a small proportion of patients that have PKD genetic disease as well, and potentially it's these in whom we see the small little cysts. So a small proportion of patients with tuberous sclerosis complex, in addition to the other findings of tuberous sclerosis, such as the angiomyolipomas, will have a bunch of cysts. And so in this patient, these little areas of high signal are cysts. Those other areas of kind of a little bit lower signal in the parenchyma are angiomyolipomas. And this is another patient. Again, one side we can see large angiomyolipoma that's exophytic and pushing the kidney, and the other side, enlargement of the kidney because of angiomyolipomas, but also multiple large cysts. And then there are diseases in whom we don't know the patient doesn't have a known genetic disease. And so the common mimickers for PKD would be things like acquired cystic disease. So this is a 63-year-old diabetic with chronic renal failure. And I'm not sure if we know why these patients are predisposed to developing renal cysts. But an easy way to differentiate acquired cystic disease of the kidney from congenital cystic disease is the size of the kidneys. These patients, by and large, will have small kidneys, whereas the large kidneys are manifestations of congenital kidney disease. So this is just by looking at the renal size, one can differentiate. Within the space of a day, I see patients with cysts in their kidneys. Probably every other patient that I look at the kidneys, whether I'm looking by CT or MR or even ultrasound. Development of cysts within the kidneys is normal part of human aging. And in fact, the same for cysts in the pancreas and cysts in the liver. So cysts in the kidney, pancreas, liver, and other organs are very, very common as a normal part of aging. And so sometimes we do see patients that have a lot of cysts but don't have necessarily renal failure and don't have any history of PKD disease or mutation indeed. So sometimes we see florid cysts, so it's possible that these patients have no genetic disease necessarily, or it could be that there are just some predisposition because of mosaicism, which Dr. Pei will get into as well. Once in a while, I get a call from Dr. Pei's clinic asking me to have a look and see if indeed a patient does have polycystic kidney disease or there is another disease. Often Dr. Pei has looked at the imaging, has picked up on the fact that this is not the typical cyst, but in fact, these structures that are fluid-filled, they actually communicate with each other, and this is a dilated renal collecting system. This is a case of congenital pelviureteric junction obstruction, and in these patients, they tend not to get pain, although occasionally they can present with pain when they've been drinking beer or get a lot of large water fluid challenge. These patients can be diagnosed by the fact that the kidney, despite the fact that it looks obstructed, generally has normal renal function, so that can be shown by nuclear medicine renal scan, for example. There's symmetrical renal function. So despite the dilatation, there is no affecting the filtration ability of the kidney. Another entity that occasionally gets mistaken for cystic disease is development of parapelvic cysts. And again, parapelvic cysts are also things that we see in normal patients with no clinical manifestation. In fact, it's over my career, I've only seen 1 or 2 patients that have had hemorrhage within these cysts, and they came with clinical symptoms. Otherwise, they're just mimickers of the patient. People mistake them for either obstruction of the kidney or occasionally cystic kidney disease. So they tend to be quite asymptomatic and not clinically relevant, just to make sure that we don't mistake them for anything else. Very good. So now I'm going to move on to total kidney volume. And you've heard this morning quite a bit already about TKV. It has diagnostic and prognostic value. When it's adjusted for height, the performance in terms of prognostic value significantly improves. It's a biomarker for disease progression. So how do we measure total kidney volume? We can measure total kidney volume using the gold standard, which is slow and methodical, manual segmentation it's called. That means separating the kidney from the background tissues by hand. There are other shortcuts, so stereology, ellipsoid formula, which you've heard about this morning, and there are in development automated and semi-automated segmentation techniques as well. So we've already heard this morning that there is a correlation between the height-adjusted total kidney volume and the development of renal failure or loss of renal function over time. So the bigger the kidneys, the more likely that the renal function is going to be lost over time. So that's why we measure height-adjusted TKV. How do we do manual segmentation? Typically, somebody with anatomical knowledge or radiological knowledge is going to sit and by hand go around and mark out where the kidney is. And we do this through on every slice or every other slice going through the entire kidney. These are large kidneys, so it takes some time. That's why we do it in the coronal plane, because the number of slices are less in the coronal plane than in the axial. There's less slices to go to. The kidneys are longer in this direction than in the front to back. So this is very accurate and reproducible technique. We do it for measurement of other organs as well. It's very familiar, but very time-consuming. And it is expensive because you need an MR or CT, but also you need somebody to sit down and go through and do this. It takes 15 to 20 minutes. It's a moderate value prognosticator. So it's great, but it's not that great. It's the gold standard, but it's not a perfect method. The other methods that I'm going to talk about with regards to TKV are going to be estimate methods of the manual segmentation. And so one you've heard about is the ellipsoid formula. And so your radiologist might not be used to measuring the kidneys in this way. We use the ellipsoid formula all the time in radiology. So, you know, the radiologists know you just take the three orthogonal measurements and you multiply them by pi over 6, which is 0.52, and you get the volume. But to make this a little more accurate estimation of TKV, the formula, it takes the average of coronal oblique and sagittal oblique. So the mean of those two plus the largest transverse dimensions in the other. So this is something that radiologists do all the time. We usually just measure one, not both, and taking the mean of the coronal and sagittal. So it's not complicated, and there is a calculator which basically does this online, as you've heard as well. So how well does ellipsoid formula do versus manual segmentation? There's published data, and these are our own data as well, showing that generally ellipsoid formula does pretty well. About 2/3 of the patients lie within 10% of the volume measurement, and about 95% of the patients or so, 93% of the patients fall within 20% of the measurement with with regards to manual segmentation. So it generally tends to do pretty okay. People are developing software to recognize the outlines of the kidneys and do the segmentation automatically or semi-automatically. But I'm going to show you what the challenge is. So the challenge is that, so here we can see this is a coronal view of the kidney, and there is the liver. And the liver has cysts, and the kidney has cysts. And exactly where does one begin and the other end can be difficult in some patients. Especially, you can see in this transverse view, these cysts are in the kidney, these cysts are in the liver, but this cyst is hard to know. Is this belonging to the kidney or belonging to the liver? And sometimes it's just a judgment call. And so it's hard to train and develop a system where you're not sure exactly what the real answer is either. But I'm sure they will do a pretty good job in great majority of patients. Another way of trying to estimate the TKV using a modality that's cheaper and more available is by using ultrasound. So one way is to, instead of measuring total kidney volume, is to actually estimate the kidney length. And you can see that measuring the kidney length in ultrasound, we talked a little bit about this lack of reproducibility. It is reproducible, but not to the same degree as MR or CT. But the other issue is the size of the kidney. So in these patients with advanced disease, the kidneys can get quite large, and the physical size of the probe gives you a limitation on how much of the body you can see or the organ you can see at one point. So in this patient with a kidney that's 19.5 centimeters or so, the measurement needs to be estimated. And generally, the larger the kidney, the more we underestimate by using ultrasound. We underestimate the size of the kidneys. So we've been doing some studies in terms of how well we can use renal length as predicting the Mayo class. And so the important thing is to important clinical thing is to try to decide whether a patient is low risk or high risk. And if we break the classes into the low risk and high risk group, we can see that just using a cutoff of 16.5 centimeters, the average length of the kidneys at 16.5 centimeters gives you an accuracy of about 74%, which is kind of okay. And we tend to overestimate. So we take patients from patients who are truly at low risk and overestimate them to high risk in about 14% of the cases. But we tend to do a little bit worse when we call positives, that is high risk. About 30% of those are actually low risk patients. So we're studying how well this actually can be used in the clinical world, and whether or not it's accurate enough. Another way of using ultrasound is instead of measuring just one dimension, is measure the 3 dimensions and or actually manually segment the entire kidney. So this is a semi-automated method of getting the kidney outline, volume. And so using ultrasound by measuring ellipsoid method or 3D ultrasound. And so using 3D ultrasound requires a special probe that automatically goes through the entire kidney and acquires the volume of the kidney, and then somebody has to go around and estimate where the kidney is. The software does help you a little bit. With just like other measurements with ultrasound, we found that there is some degree of decreased accuracy in very large kidneys, and we're studying that to see if 3D volume is also potentially a useful clinical tool when acquired by ultrasound as an estimate of manual segmentation, MR, manual segmentation. Okay, and then finally, going beyond total kidney volume. So, when I started working with Dr. Pei, I was first struck by how well and how quickly he could tell by just looking at the MRs some specific things about the patients, including what type of genetic disease and how much renal function they would have and whatnot. So he would look at the kidneys and he would look at their age and basically, that degree of estimate, which he's gained by experience, you can try to quantitate by using new imaging tools, such as texture analysis, where you get quantifications of cyst sizes, the uniformity, the symmetry, the distribution, randomness, and a whole bunch of other features. And when you put all of these features together, there is a recent publication that has shown that this tends to predict 30% drop in renal function at 8 years, a little bit better than height-adjusted TKV. And so there are additional techniques that people are working on that will may improve on height-adjusted TKV, and this is one example. So at this point, I want to stop. I have 10 seconds, so I was right on time. I want to stop and thank you very much again for listening to me. Thank you, Dr. Pei.
Thank you.